Welcome to our video on burns. Let's get started. We'll begin this lecture with a general overview of burns, particularly thermal burns and chemical and electrical burns. And then we'll move on to discuss an approach to burn injuries in the emergency department. Let's start with thermal burns. Thermal burns are classified into burn degrees based on the extent of tissue involvement. First degree or superficial burns affect only the epidermis. Second degree or partial thickness burns affect the entire epidermis and some parts of the dermis. Third degree or full thickness burns affect the entire epidermis and all of the dermis. And finally, fourth degree burns inflict injury to the epidermis, dermis, and all underlying tissues, such as adipose muscle or bone tissue. Here's an image that illustrates the layers of the skin in great detail. Once again, the deeper the burn injury, the greater the tissue involvement, and the higher the burn degree. First degree burns are confined to the epidermis, right here. Second degree burns go deeper to involve parts of the dermis. Third degree burns take out the epidermis and dermis entirely. And finally, fourth degree burns incinerate all layers of the skin. When it comes to clinical features, first degree burns resemble a sunburn. That is, they appear as localized, tender, and blanching areas of erythema. Notably, first degree burns display no skin blisters and have an intact capillary refill. Here's an image depicting a sunburn or a first degree burn. Note the well-demarcated area of erythema and lack of skin blistering. Second degree burns typically present as tender, edematous, and sometimes mottled areas of skin. Unlike first degree burns, second degree burns always have skin blisters, which helps distinguish them from first degree burns. Here's an image depicting a second degree burn about 2 days after the inciting event. Note the significant area of erythema, as well as the large blister in the middle of the burn, which we can see right here. Once again, the presence of skin blisters on exam images or in question stems is more consistent with second degree burns rather than first degree burns. Third degree burns present as painless white, charred, leathery areas of skin that do not blanch with pressure. Once again, third degree burns are painless, which is in direct contrast to the painful first or second degree burns. Hence, pay attention to whether burn injuries are described as painful or painless in question stems. Here's an image of a third degree burn about 8 days after the inciting event. Notice how this burn extends deeper into the skin when compared to first or second degree burns. Additionally, note the white, leathery skin around the rim of the burn injury consistent with a third degree burn. Fourth degree burns present almost identically to third degree burns with painless white charred leathery areas of skin that do not blanch with pressure. The key difference is that fourth degree burns are frequently described as disfiguring in question stems, so it's important to pay attention to this important clue. Here's an example of a fourth degree burn affecting this individual's fingers. Note the extensive charring of the skin as well as the significant disfigurement of the fingers. Alright, so let's try a quick question. What is the degree of burn injury to this patient's palm? The correct answer is second degree burn because of the notable blisters here and here. Remember, first degree burns do not exhibit blisters, and third or fourth degree burns tend to appear either extensively charred or white and leathery, which isn't the case on this patient's palm. Notably, the clinician could ask the patient if the palmar lesion is painful or not. The presence of pain would be consistent with a second degree burn, whereas the absence of pain would be more consistent with a third degree burn. So again, the answer to the question is second degree burn. Let's now briefly touch on chemical and electrical burns, discussing only the most high-yield facts for exams. Chemical burns can be either due to alkali substances or acidic substances. Alkali burns are more damaging and lead to coagulation necrosis. Acidic burns, on the other hand, are less damaging and lead to liquefactive necrosis. The treatment for all types of chemical burns begins with urgent decontamination and irrigation of the affected skin with copious amounts of water. Following initial stabilization, all patients with chemical burns should be transferred to a burn center for further management. When it comes to electrical burns, the two most notable examples to know are lightning strikes and electrical outlets. The key to electrical burns is knowing the complications associated with them. Acute complications include cardiac arrhythmias, such as asystole or ventricular fibrillation, as well as muscle necrosis and myoglobinuria, as well as renal failure. The most important chronic complication to remember is the formation of cataracts. All of these complications stem from the damage that electricity inflicts on the body. As far as treatment goes, all patients with electrical burns should be closely monitored for arrhythmias in the first 24 hours and then transferred to a burn center following initial stabilization. With the general overview of burns in mind, let's now discuss a simplified approach to burn injuries in the emergency department, focusing on the most high-yield aspects for your exams. Here's an algorithm that will guide our discussion on how to manage patients presenting to the emergency department with a thermal burn. This is a simplified sequence of steps that will encompass the vast majority of testable concepts in relation to burn injuries. If a patient presents to the emergency department with a thermal burn, and it's determined to be a first-degree burn, such as a sunburn, the treatment would be with conservative outpatient management, such as pain control or cooling of the skin. If the patient presents with more extensive burns, however, they should be treated as a trauma patient, beginning with a trauma assessment of the airway, breathing, and circulation. As a side note, even though we'll be examining the subsequent steps individually, recognize that all of these steps are taken near simultaneously when treating trauma patients with burn injuries in real life. One of the first things that a clinician should look for are signs of inhalation airway injury, because airway injury can quickly lead to airway edema and thus compromise the patient's ability to breathe. Here are the 5 most important findings that are suggestive of inhalational airway injury in trauma patients with burns. These include carbonaceous sputum, signs of oral pharyngeal inflammation, such as pharyngeal erythema, facial burns, singed eyebrows or nasal hairs, and an acute change in voice quality, such as new onset stridor. The presence of any of these findings is strongly suggestive of inhalational airway injury. As such, all patients exhibiting the aforementioned signs of inhalational airway injury should be prophylactically intubated due to the high risk of developing severe airway edema. In other words, clinicians should intubate these patients before they develop airway obstruction from airway edema. Notably, burns associated with inhalational airway injury carry a higher risk of mortality for patients. Along with an assessment of the airway, the clinician should assess a patient for a history of smoke exposure, as would be the case in a patient rescued from a house fire. In patients with smoke exposure, clinicians should obtain an arterial blood gas to assess the carboxyhemoglobin levels, and if they're greater than 10%, the patient is likely experiencing carbon monoxide poisoning and should be treated with 100% oxygen. Similarly, if a patient with a history of smoke exposure is exhibiting clinical features of cyanide poisoning, the clinician should strongly consider cyanide poisoning as a potential complication and treat the patient with hydroxycobalamin and sodium thiosulfate. Once the airway and breathing have been assessed, the clinician should then determine the extent of the circulatory support that the patient needs. In order to do that, the clinician should establish the percentage of total body surface area involved in the burn. On occasion, examiners do expect students to estimate this number based on the body parts that they list as affected by the burn in the question stem. So let's take a moment to understand how clinicians can estimate the extent of burn injuries. The extent of burn injuries is typically estimated with a rule of 9s, as illustrated on this image. Beginning from the top, the head and neck constitute roughly 9% of the total body surface area. This means that a person's face and anterior neck would be 4.5%, and the back of a person's head along with the posterior neck would also be 4.5%. Next, the upper limbs also constitute about 9% of the body's total surface area each. However, the trunk can be broken down into the torso, abdomen, lower back, and upper back. Each of these components of the trunk make up about 9% of the body's total surface area, take up about 18% each, meaning that the front of each leg is 9% and the back of each leg is 9% as well. The 2 most notable exceptions to the rule of 9s are the genitalia and adult palms, that only make up about 1%. Hence, in cases of patchy burns, clinicians can use their palm to roughly estimate the percentage of body area affected by the burn. It's important to know these approximations because they guide the extent of circulatory support that should be given to the patient as dictated by the Parkland formula. The Parkland formula is used to manage patients with 2nd or 3rd degree burns covering more than 20% of their total body surface area, or TBSA. It estimates the fluid needs within the first 24 hours per the following equation. Total fluid requirement is equal to the percent of total body surface area affected multiplied by the patient's weight in kilograms and multiplied again by 4 cc's of fluid per kilogram. Half of the fluid should be given within the first 8 hours, and the second half of the fluid should be given within the next 16 hours. It's important to remember this formula because examiners may expect students to just straight up calculate the amount of fluid that a burn patient would need in the first 24 hours. Following the first 24 hours, it's generally a good idea to titrate IV fluids to achieve adequate urine output. All right, so let's try this with a question. A 25-year-old patient presents to the emergency department with second and third degree burns covering the back of his head and neck, his entire back, and the posterior aspect of his left leg. His weight is 65 kilograms. What is the minimum amount of fluid that this patient should be given in the first 24 hours? All right, pause the video and take a moment to consider this question. The first step in answering this question is to calculate the percent of the total body surface area affected by the burns. The back of his head and neck equates to 4.5%. His entire back equates to 18%, and the posterior aspect of his left leg equates to 9%. So in sum, 31.5% of this patient's total body surface area has been injured by burns. The next step is to plug in this number along with his weight in kilograms into the Parkland formula as follows. Crunching the numbers, we get 8,190 cc's, or 8,190 milliliters of fluid, which means that this patient should receive roughly 8 liters of fluid in the first 24 hours. Per the Parkland formula, half of this fluid should be given in the first 8 hours, and the other half should be given over the next 16 hours. To keep math simple, let's just say that the patient should receive about 4 liters or 4,000 mils of fluid in the first 8 hours, which means that the patient will need to receive 500 mils of fluid per hour in the first 8 hours. The remaining 4 liters of fluid should then be given over the next 16 hours, and if we divide 4,000 mils of fluid by 16 hours, we'll get a rate of 250 milliliters of fluid per hour. On exams, students may be asked to either calculate the total fluid requirements or the rate of fluid infusion, which is why it's so important to understand the math behind the Parkland formula. Now that the patient's airway and breathing have been stabilized and the patient received an adequate amount of fluids per the Parkland formula, it's time to assess the patient for complications. One of the most critical complications to recognize early in management is a circumferential eschar. Circumferential eschar is a full thickness or third degree circumferential burn that disrupts venous and lymphatic drainage of the affected tissues. As a result, it increases one's risk for developing acute compartment syndrome distal to the burn. Hence, clinicians should have a high index of suspicion for compartment syndrome in patients with circumferential eschars. And if compartment syndrome develops, it should be treated urgently with escharotomy, which is a variation of fasciotomy. So let's try another quick question. What are the clinical features that should prompt suspicion of compartment syndrome of an extremity? All right, the clinical features of compartment syndrome can be remembered with the mnemonic of 6 Ps. The 6 Ps include pain, especially on passive stretching of the extremity, paresthesias, pallor, pulselessness, poikilothermia, and paralysis. Notably, pain and paresthesias are the earliest findings of compartment syndrome, and these symptoms should be taken very seriously in patients with circumferential eschars. Okay, moving along in the assessment of complications. Some patients can develop persistent hemodynamic instability following extensive burn injuries, which should prompt consideration of a hypermetabolic response as a potential complication. Hypermetabolic response to burn injury occurs following moderate to severe burn injuries that lead to the release of inflammatory mediators and stress hormones, such as catecholamines or cortisol. The clinical features can be thought of as an out-of-proportion sympathetic response, and they include tachycardia, hypertension, hyperthermia, hyperglycemia, which occurs due to insulin resistance, and increased tissue catabolism, for example, muscle wasting. The diagnosis is clinical, based on the aforementioned clinical features in the proper clinical setting. The typical first step in management is to address the underlying burn injury, such as with early burn excision or grafting. The clinician should then offer supportive therapy to subdue the out-of-control sympathetic response. This can be achieved with beta blockers to control blood pressure and heart rate, insulin to control hyperglycemia, and careful nutritional support to offset the increased catabolism. All right, moving on in our assessment of complications. It isn't uncommon for clinicians to order wound biopsies or cultures in patients with burn injuries to assess for infection. And if those studies are positive, the patient is likely developing a superinfection of his or her burn injury. A superinfection of a burn injury should be suspected when a second-degree burn progresses to a third-degree burn during inpatient stay, or if there is green pigment or black necrotic skin around the burn wound. The most common pathogens involved in a burn wound superinfection are Pseudomonas aeruginosa and gram-positive cocci, for example, Staph aureus. Here's an image depicting a burn wound infection. Note the characteristic green hue around the burned wound that is often suggestive of a pseudomonal superinfection. As mentioned earlier, the diagnosis of a burn wound superinfection can be confirmed either with a positive wound culture or a punch biopsy demonstrating greater than 100,000 bacteria per gram of burned tissue. The treatment is with IV antibiotics, which are often selected to cover against Pseudomonas and MRSA. Frequently used antibiotics in this setting include aminoglycosides and vancomycin. An important complication of a burn wound superinfection is burn wound sepsis. So let's discuss this next in more detail. Burn wound sepsis should be suspected when a patient with a burn wound superinfection becomes hemodynamically unstable. The specific diagnostic criteria are as follows. Temperature either less than 36.5 degrees Celsius or greater than 39 degrees Celsius. Systolic blood pressure less than 90 millimeters of mercury despite adequate resuscitation. Heart rate greater than 90 beats per minute. And respiratory rate greater than 30 breaths per minute. The treatment is with broad-spectrum IV antibiotics, such as with piperacillin tazobactam. In most cases, clinicians should consider coverage against MRSA, for example with vancomycin. All right, let's try another question. What is the primary way of distinguishing burn wound sepsis from hypermetabolic response to burn injury? All right, since both of these complications of burn injuries can present with refractory hemodynamic instability, it can be challenging to distinguish them on exams. The key difference is to remember that burn wound sepsis requires a confirmed burn wound superinfection for diagnosis. In other words, patients must either have a positive culture or a positive wound biopsy. Hypermetabolic response to burn injury, on the other hand, will cause refractory hemodynamic instability in the setting of negative cultures or biopsy results. On occasion, examiners may test students on indications to transfer patients with burn injuries to the burn center. Though the list of all indications is pretty extensive, this table summarizes the most high yield of those indications, which include inhalational injury, electrical or chemical burns, burns affecting the face, hands, feet, or perineum, second-degree burns affecting greater than 10% of the total body surface area, third-degree burns, and suspected child abuse. Lastly, there are several burn injury management pearls that get tested on exams from time to time. First, you should know that lactated ringers is the IV fluid of choice for burn patients. This is because colloid solutions, for example an albumin infusion, have been shown to increase the likelihood of respiratory complications, whereas the alternative crystalloid solution, that is normal saline, increases the risk for iatrogenic hyperchloremic metabolic acidosis because burn victims require such high volumes of fluid resuscitation. Second, prophylactic topical antimicrobials, such as silver sulfadiazine, can be useful in the prevention of a burn wound superinfection. However, there is no benefit of using oral or IV antibiotics to prophylax against a burn wound infection. Third, clinicians should consider stress or curling ulcer prophylaxis in all patients with extensive burn injuries, particularly those that end up being transferred to an ICU. This is because burn patients often experience a state of hypovolemia, which can lead to hypoperfusion of the gastric mucosa and hence put patients at a risk of ulcer formation. This can be prevented with medications like the PPIs or H2 receptor blockers. Fourth and last, clinicians should consider updating the tetanus vaccination status in all patients who present with extensive burn injuries. All right, let's conclude this lecture with a multiple choice question. A 27-year-old male is rescued from a burning apartment complex and brought to the emergency department with extensive burns. He is unresponsive and has a temperature of 36.2 degrees Celsius, blood pressure of 87/55 millimeters of mercury, pulse of 110 beats per minute, and respiratory rate of 21 breaths per minute. Physical examination is notable for burns on his face and oropharyngeal erythema. There are partial thickness and full thickness burns on his back, abdomen, and lower extremities. The resident pages the burn unit in anticipation of transferring the patient to their care following initial stabilization. Which of the following is the next best step in management while the patient is in the emergency department? A. Normal saline infusion. B. Beta blockers. C. Intravenous antibiotics. Or D. Endotracheal intubation. Okay, the correct answer is D. Endotracheal intubation. This is a case of a patient presenting to the ED with extensive thermal burns. He's hemodynamically unstable, and a physical examination reveals extensive burn injuries. Importantly, he has burns on his face, along with oropharyngeal erythema. Recall from this slide that signs of oropharyngeal inflammation and facial burns are findings that are strongly suggestive of inhalational airway injury. Recall from this lecture's algorithm that during the trauma assessment of a patient with thermal burn injuries, identification of signs of inhalational airway injury should prompt urgent intubation because these patients are at a high risk of developing airway edema and subsequent obstruction. This is why option D, endotracheal intubation, is the correct answer. Option A, normal saline infusion, may be tempting because this patient is hypotensive, and we learned in this lecture that all burn patients require circulatory resuscitation with IV fluids. However, it's critical to first secure this patient's airway because of the high risk of airway edema and compromise in patients with inhalational airway injury. Additionally, remember that the fluid of choice in burn patients is lactated ringers, not normal saline. This is because normal saline can cause hyperchloremic metabolic acidosis when given in high amounts because of its supraphysiologic chloride concentration. Lactated ringers are a more balanced fluid that do not increase patients' risk for developing a metabolic acidosis. Option B, beta blockers, may also be tempting because this patient is exhibiting some signs suggestive of a hypermetabolic response to burn injury. For example, his pulse of 110 beats per minute. However, beta blockers will likely be detrimental in this patient because he's quite hypotensive and is likely volume depleted. Lastly, option C, IV antibiotics, may be tempting as a way to prophylax against a bacterial superinfection of this patient's burn injuries. However, remember that IV or oral antibiotics are not useful in prophylaxis against burned wound superinfections. Only topical antimicrobial agents are. So with this in mind, option C is also incorrect. And again, the correct answer is D, endotracheal intubation. And that concludes our lecture on burns.